My name is Dr. Omega Silva. I am an 81-year-old retired physician living in Washington, D.C. with 3 cancer diagnoses. I taught and practiced medicine in D.C. for over 50 years. I was the first woman president of the Howard University Medical Alumni Association, and I'm a former president of the American Medical Women's Association, which supports medical aid in dying. I came here today to testify, to share some important information that I learned as a vocal advocate for the D.C. Death with Dignity Act that took effect last year. It may help you decide if you want to support New York's Medical Aid in Dying Act and how to ensure the law works. If you pass it, like the law in D.C., the New York bill would authorize doctors to write a prescription for medication for mentally capable, terminally ill adults who request it, so that they can decide whether to take it to end unbearable suffering by dying peacefully in their sleep at home surrounded by their loved ones. You will hear the same false claims by opponents of medical aid in dying here in New York that were made in Washington, D.C. Opponents make identical arguments to lawmakers across the country to inspire fear among them not to give their constituents this compassionate end-of-life care option. That said, I understand your hesitation as lawmakers. This is a matter of life and death, quite literally, and you ought to be concerned about the misuse of this law and the impact it might have in communities of color. But let me tell you, as a woman of color, as a doctor, as a former president of the American Medical Women's Association, none of the concerns raised by opponents, the same concerns that your task force on life and the law warned of in its 1994 report on this issue, have come to pass. Keep in mind that the Task Force on Life and Law report was 24 years ago, 3 years before the nation's first medical aid in dying law took effect in Oregon in 1997. Since then, the evidence shows that 6 states have safely utilized this medical practice for a combined 40 years: California, Colorado, Montana, Oregon, Vermont, and Washington. There has never been a disciplinary action against any physician for practicing medical aid in dying. The data from the Public Health Authority in Oregon, where medical aid in dying has been practiced for 20 years, show that 90% of patients who use it are already in hospice. But hospice clearly has not alleviated their suffering. The data also show that nearly 1/3 of people who get the prescription never take it. But they get a real emotional benefit from simply having the medication in hand. They experience a sense of relief, a reduction of fear, and a peace of mind. Providing that kind of psychological relief is also doing the right thing for our patients. When my best friend, who graduated from Albany Medical College, was dying of breast cancer and had uterine cancer as well, she would have utilized this option had it been available in Virginia, where she lived at the time. As she was dying, she looked up at me and said, "This is taking too long." I believe prescribing medical aid in dying to peacefully and unbearable suffering is consistent with the Hippocratic Oath, an oath I have taken. Though medicine has changed dramatically in the 2,500 years or so since Hippocrates, the concept remains valid today. Do what is right for the patient. I am not alone in this belief. A 2017 Medscape survey of patients in states without medical aid in dying showed 68% of them said that they had been in a situation where they wished the patient could have taken advantage of such a practice. Medical groups increasingly endorse medical aid in dying, including the New York State Academy of Family Physicians and 6 national organizations. Numerous other medical and health groups have dropped their opposition to medical aid in dying and adopted a neutral position. They include 10 state medical societies, 9 of them during the last 3 years after seeing decades of evidence that these laws are safe. Opponents argue that people of color do not support medical aid in dying, but polling shows 2/3 of DC residents, the majority of whom are of people of color, support this end-of-life care option. I support it both as a woman of color and a physician who has treated dying patients. 5 of the 6 African American DC Council members voted for the DC Death with Dignity Act when it passed by an 11-2 supermajority. Our African American Mayor Muriel Bowser signed the bill, and our African American representative in Congress, Eleanor Holmes Norton, fought congressional attempts to veto the law. I understand your desire to be careful. Maybe you think that this law needs more safeguards, but New York's medical aid in dying is the best of the best. I commend the sponsor of the bill, Assemblyman Pollock, and for her careful consideration of the evidence across the jurisdictions that now have adopted medical aid in dying laws. And I appreciate the recent amendments to the bill, which I think make it strongest in the nation. But a word of warning, too many safeguard amendments will make it difficult, if not impossible, for terminally ill patients with 6 months or less to live to assess the law. The last thing you want to do is pass a meaningless law that cruelly promises dying people unobtainable relief from unbearable suffering. 2 examples come to mind. The DC law took effect 14 months ago, but the Washington Post recently reported that not one terminally ill patient had been able to access it, even though district officials estimated that about 10 people would do so during the first year. I testified that the problem is the law's administrative rules, which are too burdensome and complicated for both doctors and patients. In addition, Kaiser Permanente Southern California published a report in the March Journal of the American Medical Association showing that about 1/3 of terminally ill Californians who requested medical aid in dying either died before completing the process or were too ill to complete it. It is also worth noting that the Kaiser report also showed that about 1/5 of the people who requested medical aid in dying did not qualify to receive it, demonstrating that the law's core safeguards really work. I've seen palliative care and hospice programs provide extraordinary care to patients. They work wonders for many dying people and their loved ones. But there are times even the best palliative care cannot alleviate pain and suffering. Patients may suffer from physical and emotional pain, from a loss of autonomy, and from an inability to engage in enjoyable activities. These issues are legitimate. Ironically, less than 1% of terminally ill patients in authorized jurisdictions utilize medical aid in dying. It improves care for most terminally ill adults, including people who oppose medical aid in dying, by spurring them to talk with their physicians about all end-of-life care options and better utilize them. No terminally ill person has to utilize this option, and no healthcare professional, physician, or pharmacist has to participate in it if they object to it for any reason. In short, if you pass this law, those who oppose it won't have to participate. Those who do want this option will be free to ask for it. I love my work and my life, but if the time comes that my weekly Thursday chemo treatments are no longer working and my suffering becomes unbearable, I would want medical aid in dying as an option for myself and for the sake of my loved ones. Medical aid in dying is a humane and compassionate option that gives people peace of mind whether they use it or not. I urge you to give this option to your terminally ill constituents so that they won't have to suffer needlessly at life's end. I will be glad to answer any questions you have for me, personal or otherwise.
Mr. Mosley?
Thank you, Mr. Chairman. Thank you, Mr. Chairman. Excuse me. As one Howardite to another, welcome to Albany.
Thank you.
And I wanted to also wish you Godspeed in your chemotherapy. Question I had to ask, just two quick ones. In regards to the previous testimony by Dr. White, where she talked about the lack of or absence of any protective measures, when she talked about capacity assessment mandates, how do you, what's your evaluation or your assessment as it relates to communities of color?
Well, I think it boils down to having a really personal relationship with your primary care physician and being able to trust that person and having that doctor also trust you. So it comes from a long relationship, I think.
Now, this leads to my second follow-up question, is that various, particularly in communities of color and as well as in communities of low socioeconomic standing, there is no relationship between the primary care physician. Usually there is an absence of a primary care physician. Many of these individuals go to urgent care centers or emergency rooms, and that's really the only relationship they have to a medical facility or institution or personnel. How would that, and I know you talked about a poll, have you seen any disparate studies, or do you know of any disparate studies that talk about this practice for jurisdictions that have this in place and how it's impacting lower socioeconomic communities or communities of color or both?
Well, unfortunately, the only way to get in this program is to have two physicians say that you are capable of being in this program. So you have to have a relationship. It's unfortunate, as you say, that many people don't. And I'm sure all of you want to do something about that, and I would like to do something about that as well. But that's one of the things that we have to work on.
All right, thank you, Doctor.
Thank you. Other questions? Yes, Mr. Rawl.
One more.
Sure. Just a quick question. Thank you for making the trip up here for this today. You mentioned about the number of patients that data shows, will take the prescription but not actually use it. And I think you said it was 1/3 of the patients. And I understand how maybe psychologically that can bring some peace of mind to somebody, but there have been concerns raised with, if a patient does that and say they change their mind, but it's still sitting there and maybe something happens with their, diagnosis, whatever, and in a moment when maybe they're not of the strongest mind, they make a decision to follow through with it. Do you see any concern with that?
Well, there's always the concern people do things that are unlawful. And we have to look at that and do as much as we can to avoid that. But I don't think that you're going to completely eliminate that sort of thing. But hopefully, the people that the family members that the patient lives with will be will look at that and will help.
Okay, thank you.